you're started. Now it's recording the picture and it's recording the sound. And I can tell you that I just leave this thing sitting here, and even if I walk over the far corners of the room, the sound picks up just fine.
And you just connect it, you plug in to get it to show on the screen.
Right, yeah. And then, let me stop this. And this is the lecture on blood vessels. I don't think we'll get through it in one day, but we certainly will in two, which leaves us one last day next week for the lymphatic system.
And then 2 days next to follow.
And that's it. That's the end of the lectures. And then the final exam is the following Tuesday, right? It'll be during the same time and place that we meet here. So it'll be at 3 o'clock. I don't know if it'll be in this room or if it'll be across in one of the other labs at 3, but it'll be same time, same place. And there'll be a sign on the door if it's over there. And then following that, we'll do the practical at 4:30, like usual. And then you'll be done. Okay, so here's the next to last chapter, the blood vessels. And, I think Melissa always tells me that she always tells you guys that you got to watch me on those blood vessels because that's what I used to do a lot of. I did a lot of vascular surgery, and so I kind of like the blood vessels. That's a true statement. They're pretty easy, though, and we'll talk about it. So we've talked about the blood, which is the stuff we pump around. We've talked about the heart, which is the pump that makes it move around, and now we're going to talk about the pipes, okay? The blood vessels, and how does the blood, get around? That's not working well. It would really help if I would put the thumb drive in the computer.
Isn't that your wife?
That is.
And a cute little puppy.
That's Elvis. Elvis the dog out on the Deschutes River in a raft. All right, so here's the things you need to know about blood vessels. You need to know that arteries are defined as things that carry blood away from the heart. I've already mentioned that before, but just know that. Arteries split and split and split, and then they become what we call arterioles. Now, arterioles are really important because they're kind of the controllers. They control where the blood flows. Example, when you're running marathons, you don't need to send much blood to your stomach because digestion can just wait, okay? And you don't need to send much blood to your kidneys because you can just hold on to all that fluid. You don't really manufacture any pee while you're out there running. So it's the arterioles that kind of clamp down. The arterioles have smooth muscle in the walls of them, and they clamp down and prevent blood, or at least prevent a lot of blood, from going to the areas that you don't want blood to go to. Arterioles are also important because when they do clamp down, they increase your blood pressure, which is also important sometimes. Okay, but beyond the arterioles, when it gets smaller and smaller, they become capillaries. Capillaries are the smallest blood vessels. Usually they're small enough that the red cells have to line up one by one to go through them. You remember those things called rouleaux, those stacks of red cells that stack up to get through the smallest capillaries. But also remember that the capillaries is where the action happens. That's where the capillaries give off their sugar to all the tissues around the body. It's where they give off the oxygen that they picked up in the lungs. It's where they pick up the carbon dioxide and any other waste products. That all happens in the capillaries, and then they're carried back, and the body gets rid of them. As the capillaries get bigger and bigger, we call them venules, which is nothing more than little veins. And then as they get bigger and bigger, we call them veins, and they carry the blood back to the heart. Okay? Now, there's another set of arteries that carry blood to the lungs. The pulmonary arteries carry blood away from the heart, go into the lungs. They go through the arterioles. As they go into the lungs, they get smaller and smaller. They become capillaries. They pick up the oxygen. Then they head back to the heart through another set of venules and veins back to the heart. Okay? So there's really two sets of, there's two circulations that we're always talking about here. Vessel walls, what are the pipes like? Well, they have three layers. We call them, they're really complicated to name. They're called the tunica intima, the tunica media, and the tunica externa. Tunica means tunic, like a coat, like a layer. Okay? The tunica intima is the innermost one, also called the endothelium. The endothelium is the endothelial lining that I've already talked to you about before because it can resist clotting and allow the blood to slide by it. It has a connective tissue layer. It also has an internal elastic membrane. And I have to tell you right now that when you're looking at these things under the microscope, it's this internal elastic membrane that stands out and is pretty obvious a lot of the time to, I'm going to get that arrow out of the way, to help you decide whether it's an artery or a vein. Now remember that the arteries are getting blood straight from the heart and it's under pretty good pressure. So arteries are thumping, and they're pumping, and they're exposed to a lot of pressure. And that's why, when you put your finger on your radial artery here, you can feel your pulse. You're actually feeling the beats of the heart pumping the blood, and it causes your arteries to expand a little bit, and then they come back to normal size. Waiting on the next heartbeat, then they get big again and go back. By the way, if you're looking at an aorta, and you're looking at one of the really major blood vessels, you can actually see them getting bigger and smaller. These you can just kind of feel it, but others you can see it. The tunica media is the middle layer. The middle layer just contains a bunch of smooth muscle, so it's the one that's going to clamp down to send less blood to an area. And obviously it holds the inner and the outer layers together. There is an external elastic membrane in the tunica media. But here's the thing that I think is most important that you know. The tunica media is where, in the medial part of the blood vessel walls, is where arteriosclerosis forms. It's where the cholesterol is laid down that's going to narrow the arteries and lead to most of our death, either in our coronary arteries causing us to have heart attacks, or in our neck arteries causing us to have strokes, in our kidney arteries causing us to have kidney failure, in our legs that will cause us to have amputations. All of those things are all vascular diseases caused by narrowing of the arteries, by buildup of cholesterol, and when it builds up in the tunica media. The outermost layer is called the tunica externa, oftentimes referred to as the adventitia. Remember, we had an adventitia around the esophagus. Actually, we haven't gotten to that yet. But around the esophagus, it doesn't have a peritoneal covering. You'll hear that word adventitia a lot from here on in, I guess. Anyway, it's just kind of a bunch of layers of connective tissue. They're kind of disoriented, and they have little blood vessels going into them called the vasa vasorum, which, as you say here, says the vessels of vessels. And just like the heart muscle itself has to have coronary arteries carrying blood to the actual heart muscle of the pump, some of these biggest arteries are so thick, and you've seen them on your hearts, the aorta, you see it's that thick. Well, it can't just diffuse oxygen into that. So they actually have little blood vessels that carry blood into the wall of the aorta and to the large vessels. And those are called vasa vasorum. And they basically just supply the cells of the wall of the blood vessels with oxygen and so forth. Does that make sense? Okay, here's some pictures. These are pretty good, actually, I think. Think of this as an artery on this side. Think of this as a vein on this side. Here's a picture in the middle, shows an artery right here. Arteries are usually always round, even under the microscope. The reason they're round is because they have all these elastic layers in them that kind of pull them together, so they're round. Veins have very thin walls, relatively speaking. They're also bigger, so that you actually have a lot more blood in your veins at any one time than in your arteries, just because the walls kind of relax and it serves as a place for blood to sit around and stay. Look at over here at the artery. Here's the three layers: the intima, the media, the externa is this kind of loose adventitial layer on the outside. But please notice this. Here's the endothelium, which remember is simple squamous, right? Simple squamous epithelium. And then there's this elastic layer, the internal elastic membrane, which you see there. And it's kind of got this very universal squiggly to it of the elastic membrane as it's contracted. And so that's going to in and out with each heartbeat. But when you look at it under the microscope, this elastic membrane is usually quite visible. And it's also what we would call refractile. You know, it refracts the light as it comes through it. So if you get look on an artery under the microscope and you go down here and grab your fine focus and kind of move it back and forth, the internal elastic membrane will kind of blink at you as the light gets refracted as you move that fine focus a little bit back and forth. Okay? You don't see that, call me over, I'll show it to you. So that's pretty much it. Notice that there is this elastic membrane here on the inside in the inner layer of the tunica intima, and there's another one out here on the external elastic membrane. Believe me, it's a lot less obvious than the inner one is. Here's what a vein looks like. It's a lot thinner, actually. It has an endothelium, which is also simple squamous epithelium. It has some muscle in the wall, but not near as much as the artery did. It has a tunica externa or adventitia around the outside of it. But I think the main thing is it doesn't have all the elastic fibers. It doesn't have the elastic membranes. Veins are pretty floppy. They can open and close, and they're not rigid. They don't carry any significant blood pressure in them. You know, the blood pressure in an artery will be, like 120 over 80. Blood pressure in a vein is probably going to be 8 over 0. Very low blood pressures in veins. The blood is just trying to get back to the heart. Okay, so vasoconstriction and vasodilation. Basically, you've got all been vasoconstricted before if you were in the cold wind outside and your face is starting to get cold. You're going to vasoconstrict. All the blood vessels in the skin are going to shrink down. You're going to look really pale or white, and that's because you don't want your body sending a bunch of blood to your face when you're outside, because if you send a whole bunch of blood here, it's just going to radiate that heat, and you're going to lose that heat, and you're going to get colder. You're going to get hypothermia. So that's an example of vasoconstriction. And vasodilation is just the opposite. That's when you're inside and you're nice and warm and your skin is all red and your blood vessels are all vasodilated, and that shows that you're sending lots of blood to that particular area and you're radiating the heat off of you. Okay. Now, this vasoconstriction and vasodilation, I want to talk about that in terms of afterload on the heart. I talked to you guys the other day about the cycle, the cardiac cycle. And if you remember on the front side of the systolic heartbeat, the pressure's way down here low in the ventricle. And then it starts on this really big steep rise. Remember that? And when it gets about 2/3 of the way up that slope, there's a little notch right there, a little bullet point that says that's where the aortic valve opens. Okay? So sure enough, the pressure is now built up enough that the aortic valve opens, and then it keeps going up a little bit higher, and that's as the blood pushes out of the heart up into the aorta, and then it comes down, and as it comes down a little bit, it goes boop, and there's another bump, which is called the dicrotic notch. And the dicrotic notch is what happens when the blood comes back and it causes the aortic valves to slap shut, and that gives you an extra little hook there in it. If you put in an arterial line, and I know that some of you who work on ambulances and in emergency rooms and places like that, I'm sure have done that, or at least seen them. God damn it. Excuse me.
I'm just gonna start bringing my markers.
That would be really nice if you would do that, because, you know, generally there's a set in here, but, well, here's a couple. All right, so here's what an arterial line tracing looks like. It looks like this, comes down, and there's a little notch in it right there, like that. And that little notch is called the dicrotic notch, and that's where the blood is all shot up out of the heart. The aorta has expanded. Now it's through shooting, and it comes back a little bit. The aorta contracts down on it a little bit. Blood flows back just a little bit, and it snaps that aortic valve shut. And that's what this is right here. This is called the dicrotic notch. Notch, N-O-T-C-H. Okay. Now, the other point that I wanted to make, and I thought about this the other night, but because I didn't emphasize this point to you. I talked about afterload the other day when we were talking about the cardiac cycle. And afterload is the amount of strain that is on the heart. And afterload is not a good deal. And so if you looked on this side of the big, this is the LV pressure, remember? And you remember that up here was the aortic pressure. And aortic pressure kind of came down like this till it got to about 80. So here's about 80. Okay? And then at this point, this is when the aortic valve opens. So the AV, no, not AV, the aortic valve opens. And once that aortic valve opens, then blood can actually start flowing out into the aorta, right? And that's really what the heart's all about. It's about pumping blood around, right? Afterload, the definition of afterload is how much load is on the heart kind of all the time. Now, let me draw this picture for you. If this is, let's say the patient has a blood pressure of 120 over 80. And that means that this pressure up here is 120, this pressure down here is 80, right? And it wasn't until the muscle of the heart, the muscle in the walls of the left ventricle generated this pressure up to this point here before it actually opened the valves and actually started blood flowing, okay? And then when it gets to up here, the heart is kind of shot. It's wide, and now the blood comes back a little bit. And so all of the ejection of the heart is going to take place between there and there. You can buy that? Now, let's just say you had high blood pressure. Let's just say instead of your blood pressure being 120 over 80, which is really normal, your blood pressure was 150 over 110. Okay? So now what's the difference? Well, first of all, I'll tell you that the biggest problem is your heart has a whole lot more afterload on it. It has a whole lot more work to do. Now, why is that? Well, because now, here's the heart starting to pump. It gets it up here to 80, but that doesn't open the aortic valve yet, does it? It has to keep on going up until it gets to about here. It's pushing that much harder. It's got this afterload on it. It has to increase the pressure up here to 110 until the aortic valve opens and you actually start blowing blood out, okay, until you actually start pumping. So your heart has had to generate an extra 30 millimeters of pressure with every single heartbeat to make blood move, okay? Now, sure enough, the heart is going to work really hard, and in order to empty itself, it's going to have to push it up to 150 here. But this is really what afterload is about, and this is really what high blood pressure is all about. This is why you don't want to have high blood pressure, because every heartbeat, your heart has got to work. It's got to generate that pressure up to whatever your diastolic number is up here, whether it's 80, which is normal, or if it's 110 or 120. It's got to generate all that extra work before one drop of blood flows out of your heart. Okay? So when you read the word afterload in your going through that chapter and going through that cycle, that's really what I'm talking about. That's what we're talking about, is afterload on the heart is resistance to flow. Okay.
Could you tell us more about the 150 then? So if the valve's open at 110, why does it go,
Well, because the heart wants to empty itself.
okay, how about if it was 190 over 90? Could it be that?
Yeah,
Okay, so what would it look like then? It was
it'd be the same thing. It would have to generate up to 90 till the valve opened, but
right,
then it has to go all the way up to 190
before
it's actually pushed it all out. Now, the reason it might be 190 is because those blood vessels, the aorta, maybe it's calcified, maybe it's really hard. In an old person, the blood vessels, the aorta, for example, doesn't expand with each heartbeat anymore. It just stays like a rigid pipe because it's all calcified. And so the pressure will shoot a lot higher.
To make sure that all the blood.
Well, you still want to, you've got to eject an ejection fraction to make anything happen, right? So, yeah. All right. I'm sorry I kind of digressed there, but anyway. I'm sure you'll never forget what I just said, right?
Doesn't the muscle of the heart thicken too with high blood pressure?
Yeah. What the muscle of your heart does, it works harder because it wants to. Because it's got these controls on itself that say, hey, wait a minute, we've got to pump this much blood. We've got to eject a certain amount. We've got to eject this ejection fraction out. We're going to come back to that. Okay. So peripheral blood pressure is obviously what we're talking about here, depending on how much vasoconstriction there is. Capillary blood flow is the amount of flow that goes through the capillaries, which is really, when it all comes down to it, this is really what the whole idea of the cardiovascular system is. It's to pump enough blood to all the capillaries in your body that then service all the tissues of your body. Make sense? So, as you leave the heart, and you head out to the capillaries, the arteries are going to change, and they change a lot. The first ones, the big ones, as they come out of the heart, they're very elastic. They're called elastic arteries, and you can actually see them get bigger and smaller with each heartbeat. Okay. As they go farther on out, say they're going down your arm here, they become more muscular. They have a lot of muscle in the wall of them that controls the amount of blood flow that might flow to that part on downstream. And indeed, it's the arterioles, which also have blood muscles in them, that are the last ones before they really get small and become capillaries. Arterioles are really kind of where it happens. I think I mentioned that before. Arterioles are pretty small. They can change depending on sympathetic or endocrine stimulation. Think sympathetic, think fight or flight, think epinephrine, right? Think tiger in the room. The more constricted the arteries are, the more opposed to blood flow that is, and that is called resistance. And that's why we call the arterioles the resistance vessels. For example, the tiger walks in the room, I get this big rush of adrenaline, I get this big rush of sympathetic tone, and that sympathetic tone says, well, wait a minute, we're going to be fighting or flighting that tiger right there. So we don't want to be sending blood to things we don't need to send blood to. Let's quit sending blood to the stomach. And suddenly the arterioles of the stomach clamp down, and you're not sending hardly any blood to the stomach anymore. The arteries of the kidneys clamp down and you're not sending any more blood to the kidneys for a while. Okay? Now, that's a good thing because that frees up that rest of that blood to go other places, right? It also, because you've now got all of these different beds of blood flow beds closed off, it generally raises your blood pressure, which is also a good thing if you're facing a tiger, to have your blood pressure up there so you know everything is ready to react full speed. Yeah. An aneurysm, aneurysm is a bulge in an arterial wall. The most common kind of aneurysms are located in the aorta, what we call the infrarenal aorta. So if here comes the aorta down, here's the renal arteries going to a kidney on one side, going to a kidney on the other side, and starting about 2 centimeters down here is where most aortic aneurysms occur, and they bulge out like this, and then they come down here and divide into the iliacs and go down your 2 legs. So they occur right down here. This is an AAA, an abdominal aortic aneurysm. We used to operate on them when we found them. If they were big enough was 5 centimeters, about this big. And usually you could diagnose them on physical exam simply by putting your hands on somebody's tummy down here right below their belly button, and your fingers would go plump, plump, plump. And if indeed your hands were going this way, that was usually the sign it was an aneurysm. If you just felt the pulse and your fingers would go this way, that was pretty normal. Yeah. And the surgery to fix an aortic aneurysm was you go in there, you give them some blood thinner, you put a clamp across here, you put a clamp across here, you cut into the aortic aneurysm, lay it open. Any little blood vessels that might be coming in from the back side, you oversew so they can't bleed out. And then you take and sew in a piece of cloth, a piece of Dacron cloth that goes right in here. You sew it in down at this end as well. And so now the blood comes down through here. At the end, you take all the clamps off, obviously, and the blood flows through a tube down here instead of through this weak wall. And that is a pretty cool thing because those folks, if they're 5 centimeters, they have about a 5% per year chance of rupturing. And when people have a ruptured aortic aneurysm, that's a calamity. They usually die, unless they're pretty close to the hospital. Occasionally they'll get to the hospital still alive, and we can still fix them. But so if it's bigger than 5 centimeters, the risks are worth it, and you get it fixed. Yeah.
What sort of symptoms would somebody who has one of those?
Usually they don't have symptoms unless it's rupturing. If it's rupturing, they get bad pain in their tummy and in their back. You'd like to find them before they get to that.
Yeah.
And you'll see a lot of these, there's advertisements on TV now about going and visiting this trailer that has an ultrasound machine in it. You can get your aortic measured. You can get your carotids examined to see if they're clogged up and things like that. Yeah.
So would CPR keep them alive longer, or would that just...
Well, CPR could help, but the problem is they don't have any blood in them. Because once this thing breaks, they fill up their tummy.
I might just bleed them out quicker if I try to...
Oh, maybe. But you got to do something. If they don't have any blood in their brain, they're dead anyway in 4 minutes. Yeah.
For this, like, what's bulging? Is it just...
It's the whole arterial wall.
Okay.
Yeah. Okay. And the problem with the aneurysm is it is being stressed on every heartbeat. It's getting bigger and smaller, bigger and smaller. And that's what gradually makes them get bigger. The other place for aneurysms, well, there's lots of places for aneurysms, but the next most common place is in the circle of Willis. I think we talked about that once before with an aneurysm that can be treated up there as well. So anyway, here's a little chart that talks about the differences between the walls of the things. If we start out here at the elastic artery coming out of the heart, we've got all of these elastic layers. We've got an intima on the endothelium is on the inside, They become gradually more muscular. There's not as much elasticity to them, not as much elastic layer. Then as they get smaller yet, they become arterioles. They still have a bunch of smooth muscle cells. They don't have any of the elastic stuff anymore. Then they become capillaries, and the book talks about continuous capillaries versus fenestrated capillaries. Fenestrated capillaries are kind of like leaky capillaries where the blood just kind of can leak out. An example of a place where that might happen would be into the bone marrow. Then they start coming back together and they form venules, which are very thin-walled and very small. Medium-sized veins might be like a vein you see under your skin here. And you see it's got an externa, media, and an endothelium, but once again, the layers are all pretty thin. And then we get to the large veins, which would be like the superior vena cava, the inferior vena cava. And you notice they're thicker. They have muscular linings. They're just getting thicker, and then they get back into the heart.
So then a medium-sized vein would be what you draw blood on and put an IV in?
Yes. So here's a picture of arteriosclerosis. This is a plaque that builds up in the media of the wall of an artery. So here's an artery that's cut across, and you notice that this is obviously the endothelium is on the inside, the externa is on the outside, the media is in between, and in this case you see the media, there's plaque here. Plaque is nothing more than cholesterol buildup. And gradually, if this gets big enough and thick enough, then it really starts impinging in here on the lumen. And so it was not uncommon for us to operate on arteries that were 99% occluded. In other words, just a tiny little stream of blood going through here. And this cholesterol had built in and closed it in from all sides, so there's just a tiny opening. And that's what you're bypassing around when you're doing heart surgery that we talked about. Capillaries, how do they work? They're small. They don't have any media really. They don't really have much in the way of an externa. Sometimes they're so small they're just an endothelial tube, as illustrated right there. They're just one cell layer thick. Continuous capillaries. I just wanted to tell you right now, don't make a big deal of this continuous capillaries versus fenestrated capillaries. I don't think it's very important. There are places where obviously the continuous capillaries, they do allow some water to fuse through the walls, but they don't let any blood cells or plasma proteins get through them, and that's a good thing. When we get to the kidney, we'll talk about some of this a little bit more in depth. One of the places that we have some kind of specialized capillaries is, remember, the old blood-brain barrier. The blood vessels that go up to the brain have kind of special capillaries in them that only let stuff through, some stuff through and others not through. Remember the cells called astrocytes, which are a type of glial cells, remember them? That function in the blood-brain barrier as well. Fenestrations, these fenestrated ones are the ones that have slits in the side of them, and they allow very rapid exchange. They let fluid and water and proteins move in and out. You find them in a few places that are where it would make sense that there's wide exchange of fluid. The choroid plexus. Remember where the choroid plexus is, Marcelon?
Yes.
Where is it?
It's
That was the follow-up question. Yes, I expected. Third
in
ventricle.
all of them.
In all the ventricles, that's right. They all have a choroid plexus.
The thing-
Remember, the choroid plexus makes CSF. Okay, some of the endocrine organs, you just kind of pour blood out in them. They need lots of blood. The kidneys, as we're going to learn next term. We obviously go through and the way we make urine, by the way, here's a little prelude to you. The way you make urine is the blood flows into your kidney and tons of fluid pour right out of the blood vessels. And then we reabsorb what we want to keep. Okay? And what we don't pull back in becomes pee. Okay, that's the way we make urine. So we have lots of these fenestrated capillaries there, also in the intestinal tract, where we obviously have to absorb lots and lots of stuff. I think I'm just going to leave this. Bone marrow, endocrine organs, spleen, and liver. These are organs that are almost like big bags of blood. I think that's fair to say. A spleen, the bone marrow, blood is just kind of dumped into them. It sloshes around through the bone marrow. It does its thing, and then it goes back out through a bunch of little veins. So these are sinusoidal capillaries that you need to know about. One of the other things is that the bone marrow, I think I mentioned before, if you've got a kid and you're trying to resuscitate a kid and you can't get an IV because all the veins are contracted or not present, you can actually do an IO, an intraosseous line. You stick a line, screw a big needle directly through their, into their shin bone, into the bone marrow of their shin. And then once you've got the needle in there, you can just pour in IV fluid because you're entering into this big sinusoid. The whole inside of the tibia is just a big bag of blood, and it finds its way out. Okay, let's talk about capillary beds a little bit. I don't want to make too much of a big deal of this because I just think what this is, the capillary beds or the capillary plexuses. We've got blood coming down through smaller and smaller arterioles, and then it empties into capillaries, and then it goes through this bed, this area that it's going to supply, and then it starts collecting and gets into veins bigger and bigger to head out. Okay? Well, we have some that are called thoroughfare channels. In other words, the blood comes in, the blood goes right through in a pipe, and the blood goes out. Okay? Others are different than that, and they get really tiny, and they act as exchange vessels. So this is a diagram, which is strictly a diagram, by the way, of arteries coming in, arterioles coming in to this capillary bed right here, and you notice that this is what they call this a met arteriole, which is kind of a thoroughfare channel. So any blood that flows through here just kind of goes right on through and heads right back up and goes back to the heart. And then some of it goes on and goes through these little, here's an arteriovenous anastomosis, which is a pure thoroughfare coming through there. And then all of these little ones have little sphincters on them, little precapillary sphincters that can be closed off if you want to send blood to this area, and they can be left open if you want, closed off if you don't want to send blood through all these little capillaries, open if you want to send more blood to that area. I just think that this is kind of just diagrammatic. The key over here says if it's got a straight line, it's just continuous blood flow, as illustrated here. And if it's dotted like this, it's variable blood flow. And that's all determined by the amount of muscle that's in the wall of the arterioles as to how much you let go through there. Here's a nice microscopic picture of the same sort of thing, showing a small artery coming in and it filtering through all these little tiny blood vessels. I don't know. Capillary sphincter is just like any other sphincter. It closes it off. It allows, it guards the entrance to each capillary, and it can open or close, allowing the blood to either go in there or not. Veins are on their way back to the heart. It collects the blood from the capillaries, sends it back to the heart. In general, they are larger in diameter than the arteries. Now, that doesn't mean it carries any more blood, because it's under a lot lower pressure in the veins. So it sort of has to have more volume, more size, in order to carry the same amount of blood than is carried through those smaller arteries, because remember, they're pulsing, they're at really pretty high pressure. So they have thinner walls, lower blood pressure, larger in diameter than arteries. The valves, there's really no pumping system to pump the blood back. So if blood comes down through your arteries and it goes into your toes, for example, and now you put it into pipe called a vein that's got to come all the way back up to your heart, that's a lot of gravity to rise against. And you'd think your body would install sort of little helper pumps along the way to help it get all the way back up. Otherwise, what would happen is your legs would probably swell a lot, and that happens to a lot of people. Now, how does it work? Well, this is the way it normally works, and that is that your veins down in your legs, back between your foot and your groin right here, usually you have about 4 sets of valves. And so the blood can come up through these valves and then it closes off, so it can't really go back. Now, what is it that pushes it up through those veins? Well, it's the contraction of the muscles of your legs. So every time I take a step across the front of the room, my muscles are squeezing the veins in my leg. They're pushing all the blood up through these valves, but it can't go back because when it tries to go back, the valve's shut. Make sense? So that's what we call the muscular pump of the venous system in the legs, and it really helps get all that blood and fluid up out of our feet. Now, you've ever heard the term phlebitis?
Mhm.
What does that mean to you?
An inflammation of the vein.
Oh, really? So what? So what if your vein gets inflamed? What's the problem?
Blood can't go through it.
What?
The blood can't go through as easily.
It can. It
Does it have
can.
something to do with the valves not working properly?
Yeah, the problem is when the inflammation gets in these valves, I mean, you won't believe how thin these tissues are. You can see through them, they're so thin, these little valves in the veins down here. So if this gets inflamed, and that's usually caused by a blood clot that forms, somebody got a thrombosis, clot in their leg, and then they got phlebitis, which is an inflammation in the area as your body reacts to this clot that shouldn't be there. And these valves then get inflamed, and so now instead of coming together nicely like they should, they don't. They kind of go like this, and they don't match up. And so blood goes up through them, and blood goes back down through them. Blood goes up through them and back down through them. And so those folks who have had phlebitis, chronic phlebitis, are the ones who you see with the really swollen legs down here. That's the sign of chronic phlebitis. Their sign is they get dark spots, kind of splotchy looking things on their lower legs down there. How does that get better? It doesn't. All you can do is treat it, and usually you treat it with support stockings, and then a lot of people at nighttime they go to bed with these basically balloons on their legs that are big things that are a machine pumps them up and lets them down, pumps them up and lets them down in order to help ease all any extra fluid out of their legs. You see us put those on everybody in surgery, because when you're in surgery, you don't move a muscle. Truly, you get paralyzed. You're laying on an operating table for 2 or 3 hours and you don't move a muscle. So the blood in your leg veins just sort of sits there, and that's a common place where blood clots form that then break loose after surgery and go to the heart and stop the heart. That's why most every patient at least will get support stockings or inflatable compression stockings put on their legs before surgery. Yeah?
So those valves are operated by our leg muscles contracting.
No.
Is that what you said?
No, the only thing that makes them work is that when the muscles contract out here, they push all the blood out of this piece of vein, push it up through the next one, and then it just snaps shut.
So what about when they're not contracting?
They're not contracting,
Just sitting here.
the blood's just sitting there.
Okay.
Moves very little. Another reason to take your aspirin a day, because an aspirin a day thins your blood a tiny little bit and prevents clots forming. We take anybody over the age of 50 in America probably ought to be taking an aspirin a day just to prevent little strokes and problems, but also this. This is why people get blood clots in their legs when they travel on long airplane rides. Okay? And why whenever you go on an airplane, you should get up out of your seat every 30 minutes and walk around a little bit, or at least do some bunch of exercises on the seat in front of you. Really piss off the person sitting in front of you. Yeah.
Is it harder on you to have a desk job or a job where you stand all day?
I don't really think that matters as long as if you have a desk job, you get up and move around. Okay. Where is the blood in our body at any one minute? Okay. So if you could instantly stop your blood flow,
That'd be freaky.
yeah. But if you could stop your blood flow right now, where is the blood? Okay, that's what we're talking about now. Where is it? Well, only about 30 to 35% of it is found in the heart, the arteries, and the capillaries, which means that the rest, about 50 to 65%, or about 2/3 of it, is found in the venous system, okay, in the veins. Remember I told you veins are bigger because they're under really low pressure. So a lot of it is in the big veins, but then a lot of it is also sitting in those sinusoidal capillary things we just talked about, like the liver, the bone marrow, and the skin. Another term you need to understand is called capacitance. Capacitance is the ability to stretch. Okay? And it has a great deal of relationship between blood volume and blood pressure. For example, if you had blood in your veins and you could compress it a little bit, or you need to put more in there, the veins, because their walls are very thin and they aren't muscular, they have great capacitance. They can just open up and take on more blood. Okay? They have no pressure. Whereas arteries and arterioles are not capacitance vessels. They've got enough stretch and elasticity and muscles in the wall that they're not going to be capacitant and allow extra blood to fill them up more. So what happens when we bleed? Okay? So you're walking down the road and you get run over and you bleed about 2 pints of blood out on the ground. Okay? Why don't you just die? You're missing 2 pints of blood. That's a lot, right? It's a whole quart. It's a whole liter. My God, it's this much. This whole thing is a liter. You've lost that much blood. What's going to take its place?
There's going to be constriction. Some things are going to.
Oh, really?
Yeah.
There's going to be.
So it's right there. We know constriction.
That's right. The veins, which suddenly don't have any blood or don't have enough, they're going to constrict so that you make the best of what you got left, right? And the arteries can contract down a little bit, but not much, because remember, they only have, 30% of all the blood is even in the arteries and the heart. So we have to figure out how can we make up the difference if we lose blood? And basically it happens because a lot of these bigger veins that are out in our body, in our arms, even these ones in our arm here that I can see in me, for example, they're going to shrivel up big time. They're going to constrict, and you're not going to be able to see any veins on my arm if I've lost a pint of blood or 2 pints of blood. That's why resuscitation is so hard. When you're trying to take care of somebody who's been bleeding from a car accident, and you get them over and say, oh, I'll just start a little IV on them. There ain't no veins. You can't see a thing. They're all shriveled up. They're all vasoconstricted as much as possible to make up for the blood they've lost.
And that's why it's better to do an arterial line or something of that nature, because the arteries can't constrict as much as the veins can.
You would never use an arterial line to give people stuff through. You use arterial lines just to measure their pressure. You might do an IO into the bone, but you've got to find a vein. Okay. I don't know if I want to think I've told you the story, but I think when things make a huge impression on your life, they never go away. And I always remember the time that I was in the emergency room at the John Gaston Hospital, the city hospital in Memphis, Tennessee, and the ambulance rolls in, and there's firemen everywhere, and there's everybody. And there's this guy on the table who looks dead. And we all and I was a medical student, I kind of stepped back a little bit and said, I don't want to get in the way, because there's a lot of these people that know what they're doing. And this young intern who was a smart guy, he sort of took control, and he said, okay, put him in Trendelenburg, which means put his feet up higher than his head, and give me an IV. And he got one of these big, huge IV needles, and he took the guy, and he felt his neck, and he felt for the edge of his sternocleidomastoid, and he tried to feel for his carotid artery. And you should all be able to feel your carotid pulse right there, but I bet, I can feel mine, I'm still alive. And then he just took this big needle and went, boom, right in there, just like that. Just medial to the sternocleidomastoid, just lateral to the carotid pulse. I don't think he even had a pulse on this guy. But he, boom, stuck it in. Immediately he had a huge IV. We stuck a huge IV into the guy. Hooked up a big tube, started running blood, started running IV fluid, started running drugs, and the guy came back to life. And I'm thinking, and I've always remembered that little 5-minute episode as thinking, geez, that guy did what he just did because he knows the anatomy. He knew where that vein was, even though you can't see the jugular vein, and I can't see the jugular vein in anybody, but he knew where it was because he knew the anatomy. He knew where the sternocleidomastoid was, he knew where the carotid pulse was, and he just stuck it in blindly and got it. Now, I never did get very good at doing jugular sticks, I'll be honest with you, because I got really good at doing subclavian sticks. And you'd lay somebody down on the table, and you take a big ass needle and stick it right under their collarbone right there, and aim it for their other shoulder, and you hit the subclavian vein, one of the big veins that goes this way. And they were great too, but that jugular vein I always remembered it. Yeah.
What's a central line?
Central line just means a line that's anywhere that the tip of the line ends up in the central circulation, either in the jugular or subclavian,
That's what I was thinking.
or in the heart. A lot of the times when you stick a line in somebody's subclavian and you feed the catheter in, you're feeding the catheter actually down into their heart. What does it really mean? It means that when you have a line in the central circulation, it's not like being out here. When you stick a line in out here and you run in some fluid, then the stuff that's in that vein there is mostly the fluid you just ran in, right? And so if the stuff that's in that IV bag is irritating in any way to the inside of the patient's veins, it's going to get real painful, and as a result, you can't inject a lot of stuff into a peripheral vein. But in the central system, you've got this tube that's going into one of these big veins, and it's like a tube sitting in the middle of a fire hose. And whatever you run in here, there's so much blood going around it that it's instantly diluted, and it won't do damage to the veins. That's really what central vein means. Okay. So, venous response to blood loss, the veins that are still there are gonna, the vasomotor centers are, you're getting ready to fight that tiger. You just bled a bunch of blood. You're in a stress situation. Sympathetic, fight or flight, all your blood vessels collapse down and squeeze down, trying to allow you to still maintain a blood pressure with the blood you got. Most of that vasoconstriction occurs in the venous system and causes this major redistribution of of what we call the venous reserve. In other words, there's a lot of blood that's just kind of sitting around in your veins all the time that you could do without. So when you lose other blood, you can squeeze down those veins and push it back sort of into the real circulation and where you start using it again. Okay? Overview of cardiovascular physiology. I think here's some terms that you need to understand, and a lot of these terms will become crystal clear to you when you do the physio-X's. Okay, the physio-X's are basically a series of little exercises in cardiovascular physiology. What helps control it? Well, obviously, a neural and hormonal, the epinephrine from the suprarenal glands, the epinephrine released by the hypothalamus, and that can increase the venous pressure, which then can increase the venous return, the amount of blood that's returning to the heart. And the more you have returning to the heart, the more you have going out. Because remember Starling's law of the heart, the more in, the more out, right? The more blood you have in the heart, the more it will pump. Arterial blood pressure can go up by simply squeezing down on the arteries and increasing the peripheral resistance. Fluid can go either in or out of the capillaries through capillary exchange. Obviously, if you're sitting around and everything is cool, you kind of like to have fluid around your cells in your interstitial spaces. But if you really needed the fluid, you would immediately suck it back into the bloodstream and use it as plasma. So that's what this is down here, the interstitial fluid in harmony with the going in and out of the capillaries down there. Let's talk about a few little fancy terms that you'll become familiar with as you do those physio-X's. One is called pressure. Well, obviously, everything flows because of pressure. So if the pressure is high inside the heart, that will blow the valves open and cause the blood to flow out. Okay? The same thing goes through all the way around the circulation. It continues to flow out into the veins as long as the pressure in the arterioles is higher than it is in the capillaries. So it keeps flowing down and flowing downhill. This thing called the pressure gradient is what is the overall change of pressure. Well, let me just tell you that the entire systemic pressure gradient is the same as your systolic pressure. In other words, when your heart pumps and it blows that blood out into your aorta, it's at 120 millimeters of mercury. It's going to go down, that pressure is going to go down as it goes out into your system. It's going to go down, 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 down. When it gets out into your fingers, it's still going down, but it's not zero yet. It goes through the capillaries, it starts regrouping, it starts coming back up. Is it still positive pressure? Yeah, it's still positive pressure. That's still what's making it flow back, is that same 120 that it started with is still being burnt up as it's flowing back to the heart. So, the circulatory pressure is the pressure gradient. It's the pressure at the heart and the pressure at the peripheral capillary beds. Obviously, there's going to still be some significant pressure when it gets to capillary beds because it still has to flow through all the veins on the way back, doesn't it? This is a thing that you have in your book that is just wrong. It's in the slides that came from the book company. It says force F is proportional to the pressure difference. That is not right. It's not force, it's flow. Okay? The more pressure change there is, the faster it's going to flow. That's easy enough, isn't it? Just realize that that is a big misprint, and I think it even used to be in the book itself. But flow is proportional to pressure difference. Divided by R, what's R? Resistance. Okay, so it depends kind of on how hard vessels are squeezing. Let's talk about a few more numbers that you need to be able to understand in order to understand how this blood flows around. One is the blood pressure. Blood pressure is what we think of as arterial pressure. It's the cuff pressure that you measure at your arm here. And it's normally 120 over 80. Okay? Now, if you put a catheter into your radial artery down here and just have the catheter sticking straight up into the artery, and it's basically measuring that blood pressure, it'll give you a graph that looks like this with the dichrotic notch in it. So if you ever go into your grandma's ICU bed and visit her, and she's got an A line in, an arterial line in, it'll look like this. And that's that dichrotic notch of the aortic. I mean, it's and if you look on the graph here, this would be 120, and this would be at the 80 line. And usually it's all digital readouts these days. It just prints it out there for you, exactly what the blood pressure is from second to second, which is nice if you're in an ICU situation. Capillary, so blood pressure, capillary hydrostatic pressure is the pressure down in the capillary beds. It's all that's left is the pressure in the capillary beds, but it's the hydrostatic pressure. Now, I always have to make a point of this. When I say hydrostatic pressure, what are we talking about? When I say hydrostatic pressure, Ms. Garside, I know you're looking down really hard. What's hydrostatic pressure mean? Hydro is water, yeah. So what is hydrostatic pressure? Because you kind of got to think with Montiel.
When it's not moving?
When it's not
Pressure
moving?
When nothing's moving?
No.
Could it be referring to
When you, well, let me just give you an example. When you go to your hose outside and you're at your house and you open the valve up, the water comes out under pressure, right? And what generates that pressure?
the water itself being like, kind of like a dam?
Opening of the valve. So you mean the pressure in the water lines, there's pressure in the water lines? What gives the water pressure? The water tower. That's right. In America, we get pissed off if the pressure is different on the second floor of our house than it is on the first floor. We like to have good, strong pressure, right? Because when you take a shower, you want that water to just beat on you, right? And so we have water towers. And the water towers are up there, 150 feet, and that is creating a hydrostatic pressure of 150 feet. Now, we don't usually measure water in feet of water. We usually measure it in millimeters of mercury, right? You guys, when you go listen, well, blood pressure 120 over 80 is 120 millimeters of mercury over 80 millimeters of mercury, right? So what does that mean? 120 millimeters of mercury. Well, 120 millimeters of mercury is about how far? 120 millimeters. Millimeters are about that big.
1.2 centimeters.
How about 10 centimeters, which would be 100 millimeters?
I'm sorry.
So it'd be about this high, okay? So that's how high a column of mercury would be. Anybody ever played with mercury? You're not allowed to do that anymore. But as a kid, we used to play with it all the time. My granddad brought home a big bottle of it one time from the school, and we played with it. It was a lot of fun. Probably got a little mercury poisoning, but I don't know. Seemed to have survived it okay. But mercury has 13 times the density of water. So if you took a square box of water and a square box of mercury, the box of mercury would weigh 13 times as much. So therefore, you don't have to have a column that's quite so high. And what that enables us to do is to make a sphygmomanometer, a blood pressure cuff, with mercury in it that only has to be about this tall to measure blood pressure. If you had water in there, it would have to be 13 times taller, and that wouldn't fit in your doctor's bag. Okay. Now these days, they don't even use those anymore. They mostly just have a little gauge that measures pressure, right? All right. Okay, so hydrostatic pressure just means what you think of as pressure. In other words, how far will it squirt? How much pressure is coming down on it? Venous pressure is always really a little bit, and there's this circulatory pressure, which I told you is the whole system, and there's this total peripheral resistance, which is the total amount of friction in the system. Now remember that the stuff that's flowing through these tubes is not water, right? It's blood, and blood is thicker than water. I think there's a song about that. Blood is thicker than water. And so therefore it doesn't flow as quickly or as easily as just pure water was. And the friction causes vascular resistance. And that's due to two things. One is the walls of the blood vessels aren't perfectly smooth, so therefore the water kind of bumps up against it as it goes down. That causes resistance. And also it depends on the size of the blood vessels, okay? So when blood vessels are big, there's not that much contact with the walls, and there is not that much resistance. But when those blood vessels get really, really tiny, so that now the blood cells are lining up one by one to get through there, there's a lot of friction with the wall of the vessels, leading to a lot of resistance. So what you're going to learn in your PhysioX is that there is a great relationship between diameter and vascular resistance. In fact, it's actually resistance rises exponentially as vessel diameter decreases. What does exponentially mean, Tristan?
Multiplying itself.
Yeah. So going from 2 to 3 in a regular system would be like going from 2 times 2, which is 4, to 3 times 3, which is 9, as it went up. It's going up exponentially. It's going up by the square of the number. Okay? So it's increasing a lot. When your vessels get small, it's making a lot of resistance. What is viscosity? Well, viscosity is just the thickness, the resistance to flow. Resistance is caused by the molecules and the suspended materials in a liquid. Certainly blood has lots of protein, blood has lots of cells in it, and whole blood viscosity, which is what we're pumping through our veins right now, is about 4 times as viscous as water. Turbulence? What's turbulence? I think I told you my little story about the Deschutes River. When you're going down the Deschutes River and it's nice and wide and the river's nice and deep, the water just kind of flows along and it's quiet and it just kind of moves you on down the river. But then you come to an area where there's a bunch of rocks in the river and the river gets narrower and suddenly the river is going really fast and there's all these currents and all these eddies and all this stuff. And that's all turbulence. The blood's going in different directions. It's anything, it's a swirling action that disturbs the smooth flow. It also causes murmurs, noises, okay? And indeed, it can occur in the great vessels. A lot of times arteriosclerotic plaques will cause abnormal turbulence. In my office, I used to get 3 or 4 patients every week that were referred to me by a family doctor, and he said, Dr. Sessions, would you please evaluate Mr. Jones because he has a bruit in his neck, B-R-U-I-T. And sure enough, you'd take your stethoscope, you'd hold it up on his neck, over his carotid artery here, and you would hear it going, ch, 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 ch. That's called a bruit. And a bruit means that there's an atherosclerotic plaque in there. It's probably narrowed down to a certain degree, and you can hear it, okay?
And that's when you can have a stroke.
You can. The correlation between a bruit and a stroke is very low, though.
Oh.
It's much more important. That's why what we would do is just scan them with ultrasound and see whether they really did have much stenosis. It was the stenosis that leads to the strokes. So we'd say, well, you'd send a note back to the doctor and say, well, Mr. Doctor so-and-so, I evaluated your patient. He only has an 80%, he has 80% open, only 20% narrowing. Bruit, I think, is caused by the bifurcation of his carotid where it splits. I don't think it's anything to worry about sending him back to you.
So like an innocent heartburn where you could have an innocent
Exactly. Good point. Okay, so here's a bunch of numbers you ought to look over. You ought to be able to define every one of these because they will make sense, especially when you're doing those physio X's, venous pressure, vascular resistance, turbulence, and so forth. I think I've talked about all of them. There's a couple of relationships that you need to understand. Flow is proportional to the pressure gradient. Obviously, if the pressure here is 120 and the pressure there is 80, it's going to flow like crazy between those 2 points. If the pressure here is 120 and the pressure here is 0, it's really going to flow like crazy, right? So it all depends on the pressure gradient. Flow is inversely proportional to resistance. As the resistance goes up, the flow goes down. Make sense? Flow is directly proportional to the pressure gradient and inversely proportional to the resistance. Just putting those first two together gives you this one. I think I've said enough. This one's the kind of the real funky one here. Resistance is proportional to 1 over the cube of the radius. So resistance is inversely proportional to the 4th power of the radius. So as you lower the radius of the opening, it goes up by a factor of 4. The resistance does. I think I'll stop right here on overview. Cardiovascular pressures. Okay, I got a few more cookies up here. I want somebody to eat them because otherwise I have to take them home and eat every one of them. I don't need them.
Oh yeah.
Okay, so this is the next to last lecture in A&P, second term. We'll finish up blood vessels, and then next time we'll try to get through the lymphatic system and a little bit about antibiotics and resistance, things like that. Basically result from lymphocytes, which are part of blood cells, remember? Let's push on through the rest of this. There's some really interesting stuff in here. And I think you need more shoes on than that. It's cold outside. So let's talk about pressures a little bit. I think these things you should know. Systolic pressure is the highest your pressure ever gets to. It's when you take it with the cuff. It's when you first start hearing the beats coming through, that's the highest number. Usually it's about 120. Hypertension, high blood pressure is when that gets too high. Diastolic pressure is usually about 80 or 90. So 120 over 80 is the number you should know in this class, at least, as normal blood pressure. Systolic pressure is 120. Diastolic pressure is about 80. Hypertension can be in 2 forms. Hypertension can be either systolic hypertension, where just the top number is high, or it can be diastolic hypertension, which is probably the more dangerous form of hypertension, which is where the diastolic pressure is too high. But nonetheless, hypertension means high blood pressure. Pulse pressure is the difference between the high pressure and the low pressure. And by that I mean If your blood pressure is 120 over 80, your pulse pressure is 40. Okay, that's the difference between the systolic and the diastolic. Now, obviously, when you're feeling somebody's pulse or feeling your own pulse with your fingers here, you're feeling the difference between the two. You're feeling the fact that the pressure goes up and down, up and down. You can't say anything about whether the person has a high blood pressure or low blood pressure based on what their pulse feels like. Okay? All you can comment on, if they had a pressure like this, that was a real high and a real low, then you might be able to detect that with your fingers. But in general, your fingers are only valuable for feeling that there is a pulse, their heart's beating, and checking their pulse rate, see how many times a minute it's beating. That's about all it's good for. This is an important term here called mean arterial pressure. Mean arterial pressure says, and think about it like this, if your blood pressure is 120 over 80, for example, what's the average pressure that it is during that whole heartbeat? Well, at part of the heartbeat, it's way up there at 120, and part of the heartbeat, it's way down here at 80. So how do you figure the mean arterial pressure? MAP is a number that you'll see talked about a lot. Well, the way you do it is you figure that since your pulse is about two-thirds of your cardiac cycle is diastole, and about 1/3 of your pulse is systole. Oh, we're selling out of chairs. That's pretty good at the end of the term. Wonder by some of the classes towards the end of the term, and there's like 6 people left.
Not here.
It's kind of spooky, isn't it?
We're multiplying.
We're multiplying. God. I hope I don't have to explain that. Anyway, so this thing down here, the difference there, that's the explanation. The explanation is that since we spend about 2/3 of our cardiac cycle in diastole and 1/3 in systole, basically to figure the mean arterial pressure, you add 2 times the lower pressure, add 1 times the upper pressure, the systolic pressure, and that gets you your mean arterial pressure. And here's another way to figure that. Here, this little formula. You take the diastolic pressure, which in this case would be 80, plus 1/3 of the pulse pressure. Pulse pressure is 40, right? Plus 1/3 times 40, and that would give you 13 plus 80 would be about 93. Okay? That means throughout your whole cardiac cycle, on average, the blood pressure is 93. That's your mean arterial pressure. Okay? Okay, abnormal blood pressures, I've told you 120 over 80 is about normal. Hypertension is when it's higher than those numbers are higher than this, say. One of the problems with blood pressure is it's very variable. So if you just went out to McDonald's and ate an order of French fries, which has 2,300 milligrams of sodium in it, your blood pressure is going to probably be up. Another thing that happens is when people go to the doctor's office to get their blood pressure checked, it usually goes up. Call that white coat hypertension for obvious reasons. People get nervous when they're in a doctor's office, I guess, and that raises their blood pressure. So making the diagnosis of hypertension is not all that simple. Obviously, if it's super off the ceiling, it's made. But if it's not, then you probably need to check it a number of times, have the patient come back into the office when the doctor's not around, check it a few times, or go to one of these things in the grocery store, but basically just record your blood pressure a number of times. I would also say that these new machines. They're about this big usually, and they have a cord coming out of them and a blood pressure cuff on. They're automatic. You just hit start and it blows it up for you and lets it back down. Those things have gotten very accurate. Those are a very good way. And if you don't have one in your home, it might be it's a worthwhile purchase. You can get it for Christmas. Check your blood pressure every so often. It's a good deal. It will extend your life if your blood pressure is too high. Hypotension means just the opposite, an abnormally low blood pressure. My wife's blood pressure runs about 85 over 50. Now, is that low blood pressure? No. She's super healthy. She's super skinny. She's runs and she exercises and all that stuff, and 85 over 50 is perfect for her. That's a perfectly normal blood pressure. All you need is enough blood pressure to pump to your head when you're standing up, right? And as long as you got enough blood pressure that you don't get faint or dizzy when you stand up, then whatever blood pressure you got is just fine. I told many patients, blood pressure, as long as you're asymptomatic, it can't be too low. Lower the better. It's easier on your heart. The lower your blood pressure is. Yeah.
What happens if you do have a patient that when they stand up they get lightheaded and stuff?
Well, then you got hypotension. Then you got to deal with it. You got to do something to raise their blood pressure.
Is it medication?
Or they're dehydrated.
A lot of times they're just dehydrated. Good point. A lot of times they just need salt. A lot of times they've been sweating too much. They're dehydrated.
So it would have to be like a consistent thing in order to be diagnosed
Correct.
as hypotension.
Most people don't run chronic hypotension like they do run chronic hypertension. The blood pressure is partially controlled by the elastic rebound in the wall of the arteries. When the heart beats and pushes all that blood out into the aorta, the elastic arteries, the great big arteries, expand a little bit to take up some of that pressure, and then during diastole they kind of come back down to use that stretch, that rebound, to keep the blood moving. So the blood moves throughout diastole as well. It doesn't just go whoop, out, stop, whoop, out and stop. It's always flowing. This is kind of an interesting diagram. This is a weird one, really. You have to conceptualize this graph. But if you think about this, this is a trip around the bloodstream, from the aorta, the big blood vessels, to the elastic arteries, to the muscular arteries, to the arterioles, into the capillaries, and then coming all the way back to the heart. The venules, the bigger veins, the large veins, finally the vena cava. And then it comes back into the heart. Well, look at this. Notice where it comes back into the heart. It comes back into the heart at about 3 or 2. So it's under pretty low pressure when it's made all the way around the circuit. When it starts out, when it leaves the heart, it's under very high pressure. And notice that with each heartbeat, the pressure is going up and down. And sure enough, there's a pulsatile pressure in your aorta and in your elastic arteries, which would be like your subclavians and so forth, and even your radial arteries, until you get way out into here, into the smaller arteries, then we would call them muscular arteries. Then arterioles. Remember, arterioles are kind of like the gatekeepers. They're the ones that have all the muscles in the wall that open up capillary beds or close capillary beds off, depending on where we think we want to send blood to. So then it kind of quits being pulsatile. It doesn't beat anymore. So if you put your fingers on capillaries, it's not really beating like it was back here. Now it's just kind of a steady pressure, and notice that that pressure is gradually getting lower and lower and lower and lower until it gets back to the heart. Now, without confusing you here, just let me tell you that when the blood pressure is this low, which it is, coming back into the heart, then what we are doing in terms of breathing actually changes the flow into our heart a lot. For example, when we take in a deep breath, we do that in order to suck air in, right? But the way we do that is we expand our rib cage and air flows in through our trachea to fill up our lungs. Well, at the same time that we're sucking air in, we're also sucking blood in. You can see how low the pressure is. So when you go, you actually get an extra bunch of blood flowing into your chest when you lower the pressure in your chest like that. It's not illustrated there, but just so you know, it really does that. And you can clinically see that with a blood pressure cuff even. Okay, so what are the forces that cause blood to flow, and what causes blood to either leave arteries or to stay in arteries? Okay, and this basically, I just told you that the pressure, the pressure that I was talking about on that last slide is what's hydrostatic pressure. In other words, it's pressure. It's like caused by the water towers that give us water pressure, right? It's pressure due to gravity. And in this case, it's due to the pumping of the heart. But we also have another kind of pressure that has a lot to do with our blood flow out in the capillaries. And that is that we have, as blood flows from the arterioles over here into the venules, we notice that we create what's called a net filtration pressure. Net filtration pressure. And it's about plus 10 millimeters of mercury. Now, how do we get that? Well, that is a combination of two pressures. First of all, it's the pressure it's the hydrostatic pressure from that previous picture. About 35 millimeters of pressure is still left in the arterioles. So that's blood pressure that's pushing blood out through the wall of the capillaries. But notice that there's also 25 millimeters of mercury pushing pressure back in. What kind of pressure is that? Huh? Osmotic pressure, that's right. Osmotic pressure is opposing that and pushing fluid back in. So we have mechanical pressure or hydrostatic pressure pushing blood out. We have osmotic pressure sucking back in. Now, why are we sucking water in? Why does water want to get into our bloodstream osmotically? What's more concentrated? Our blood or interstitial fluid? Our blood is. Our blood has lots of proteins in it, in our plasma especially. It's very concentrated. Its blood is thicker than water, right? And same thing here. This is just water on the outside. So that water, which is high concentrations of water on the outside, wants to come in and dilute the high level of proteins and stuff that are inside. So we have an osmotic pressure pulling fluid back in. Which means that there's a net filtration of about plus 10 on this side, closer to the arteries. But then as we come on through here, you notice that the pressure, the mechanical pressure, starts dropping. Now it's down to 25, and by the time you get over here into the veins, it's down to 18, it says here. So you notice that the net filtration pressure along in here is 0, because it's 25 out and 25 in. And then by the time we get to the smallest little venules and veins, it's now only 18 out, 25 in. So we're actually sucking fluid out. And remember that capillaries are kind of where it happens in our body, right? And the reason we pump this blood around is so that as this blood passes through this area, we will push things out like sugar and water and good stuff and oxygen. We'll push it out into these tissues, and then when it gets over here to the vein side, we're going to pull it back in. Okay, so that's part of the deal. I mean, that's really why we did this, why we pumped this blood around, was so that it would service these tissues that are, out in here and here in this schematic thing. Now, wait a minute. That means it's pushing blood out at plus 10 on this side, and it's only sucking blood back in at minus 7 on this side. Doesn't that mean it's going to pump more stuff out than it's going to come back in? Yes, you're right, Damian. The answer is yes. We push more out than comes back in. So how do we get the rest of it back? What's that other little capillary system that's in the body? Called the lymphatic system. Remember that? The lymph vessels. They're going to suck the rest. They're going to take in the rest of that fluid and bring it on back up to the heart through the lymph vessels. Okay, so this recycling continuously moves fluid out and back in, and it comes back through the lymphoid system as well. That serves to ensure that the plasma and interstitial fluid communicate so that they can get rid of stuff they don't want and they can bring stuff back in that they don't, flushes bacterial toxins out, transports in. Yeah. You can read that slide anywhere you want. All right. So, tissue perfusion. What does tissue perfusion means? Well, tissue perfusion means that you're getting enough blood to a certain area to supply all the nutrients and stuff that you need. Here's a little clinical note for you. I don't know if you guys can all see this as well as maybe you'd like, but let's look at my finger right there. And you notice that my finger's kind of pink. Can everybody appreciate that my finger is pink? And if I take and put my other finger on it and put pressure on it and kind of push the blood out, watch what happens. White, pink again, right? White, pink again. It should take about as long for your finger to pink back up as it takes for you to say capillary perfusion. Capillary perfusion. Capillary perfusion. I'm old. Okay? So that's a pretty good illustration right there of what tissue perfusion is. I can stop the fluid flowing through a lot of the tissue in my hand right here simply by squeezing it and increasing the mechanical pressure on it so that blood can't actually get through there. And then when I open it back up, it becomes pink again. Okay? All right, so what changes the levels of perfusion, of capillary perfusion? Well, obviously, if your cardiac output is really low, if you're an old geezer, if you've got a really bad heart, it may take a very long time. And I bet when you guys pick up people in an ambulance, one of the things you usually do is check them for capillary perfusion. You can just simply push on their finger and see if it pinks back up pretty quick. Or if it may not even be pink to start with. They may not be perfusing enough to have their skin pink anyway. Okay? Peripheral resistance is going to change things. If the peripheral resistance is real high for one reason or another, if their blood pressure is really low, that's going to lower their perfusion pressure and their tissue perfusion as well. We all want good tissue perfusion. That's what our heart is all about. That's why it's up there pumping away. That's why it's carrying that blood out through all those arteries and bringing it back. It's only doing it so that all the tissues in our body have got a little bit of blood flowing through them. And hopefully it's a little bit of bright red blood that's got oxygen in it as well. So, what is it that allows us to control all this? Because we certainly want to do that. And you probably remember these words. We have some baroreceptors. Baroreceptors means, Arsimona? Baroreceptors mean pressure receptors, like barometers. They're little barometers in your body that measure the pressure. Okay? So we have baroreceptors that tell us what our blood pressure is. And if it gets too low, they crank up and say, hey, beat harder, send out some more sympathetic, send out some more fight or flight, send out some more adrenaline, make it beat faster. Chemoreceptors. We also have chemoreceptors. What do you figure chemoreceptors perceive, Susie? Chemicals. What chemicals do you think they perceive?
Would it have to do with like fight or flight?
Well, what chemicals would it have to do with? What? Oxygen and CO2. Very good.
I didn't look, I knew that.
It's not even on there, so you
okay.
did good. All right, so the only two chemicals we really can monitor in our body, and this is kind of weird to me, because we've got all these amazing things that our body tells us about what's going on. There's really only two chemicals that we can monitor, and one of them is oxygen, and one of them is carbon dioxide. Okay? Now, we'll learn a lot more about oxygen and carbon dioxide when we get to the next chapter, when you come back after Christmas, when we talk about the respiratory system. They'll get so sick of hearing about oxygen and carbon dioxide, they won't be able to stand it, will they? It's wonderful, she said. Well, that's sweet. All right, so anyway, the way this whole thing works is we've got our blood, our heart, our cardiovascular system all working together, responding to all these physiological changes, things like exercise when we need more cardiac output, things like blood loss when we don't have enough blood and our pressure goes down, but we have to do things to fix it, okay? In other words, what we're always trying to do from day one of A&P is to maintain homeostasis, that wonderful word. So here's a couple of little things here about cardiac responses to different things. Let's talk about light exercise. We're sitting here and we start walking and we're moving pretty fast. And the first thing that happens is we want to have vasodilation. In other words, we want to open up our arteries to accept more blood, lower the peripheral resistance, right? Vasodilate to let more blood flow out through our muscles to our skin and so forth. We want to increase our venous return because if we don't get the blood back to our heart, it can't pump it out, right? So increasing venous return is really a cool thing to do, and one of the things we do that is with muscle contractions. All that blood that may have just been kind of sitting around in these big veins in our legs, not doing much, once we start exercising and those muscles start squeezing down around those big veins, it pushes that blood that's in those veins back into the system, sends it back to the heart, and increases venous return. And then, with more blood coming, and with more vasodilation, less resistance going out, and more blood coming back, we increase our cardiac output, right? Now, that is because of this Frank-Starling law, the Starling law that I mentioned to you earlier. What was the short, down and dirty of the Starling law?
More in, more out.
More in, more out. You put more blood into your heart, it pumps harder and blows more out, okay? In other words, the heart is very responsive to volume, the fluid volume that's in it. And indeed, when in medicine, one of the best things that we can control as physicians and healthcare workers is we can control people's venous return. We can give them more fluid. We can give them more IV fluid. We can give them more plasma. We can give them more blood. We can put compression stockings on them. We can turn them up. We can put their feet up in the air and their head down. All of that increases venous return and then makes their heart beat better. Okay. So so that was light exercise. Let's talk about heavy exercise for a minute. When we really get going, we've been running a couple of miles now. We've got our sympathetic nervous system activated. It's doing the fight or flight. It's beating fast. It's beating hard. Cardiac output is up to maximum, which is usually about 4 times normal. In other words, so if I'm sitting here at rest pumping 2.5 liters a minute of cardiac output, I can run that up to 10 liters a minute pretty easily. Most folks can quadruple their cardiac output when they start exercising. Heart beats faster, it's stronger, you got more venous return coming back, got all this good stuff going on. The other thing we do when we're doing really heavy exercise is we start to restrict the blood flow to unessential organs, things that aren't essential right at the moment, such as the digestive system. Now, the way that always comes home to me is I used to run a bunch of marathons, and then I volunteered at a bunch of marathons after that. And when you go through a water stop on a marathon, usually you'll just get this stuff here. It's called water, okay? And water seems to go down into your stomach and sit there for not very long and go on downstream. A lot of people, just by adding a little bit of sugar and a little bit of electrolytes, which I'm assuming this has in it, it doesn't work well for them. A lot of people, when they're really heavily exercising, they don't have enough blood flow going to their system to tolerate that. So you'll see a lot of people that go through a water stop and drink Gatorade or one of those other things, you may find them 100 yards later down there barfing because it just doesn't fit well. Why? Because they're really not sending any blood to their stomach anyway, and they just can't take anything out of the ordinary. The other thing you'll notice is that some of these water stops, they'll have bananas and apples and oranges and cookies and all this kind of stuff. And you'll see that most of the runners will just run right by it and won't even think about stopping and getting something. Because if they do, it's going to sit right there in their stomach, and you're going to hear it on every step. Bloop, 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 bloop. And then they're going to eventually vomit it back up too. Because when you're not sending any blood to your stomach and to your intestine really can't tolerate much at all. Now, science has now found some of these synthetic glucose things. Goo is one of them. Little packets of stuff that's real thick and real heavy in carbohydrates, but real simple carbohydrates. Usually it's just polymerized glucose that you can take, and maybe your body will tolerate that. But even that, don't ever use that stuff unless you've practiced using that stuff. When you were doing your training workouts, if you weren't using goo, don't go to the race day, and just because they got goo sitting there, try it. You won't do well with it, more than likely. Okay, so that's one of the areas that we make less, don't send much blood to. Another one is your kidneys. It always cracks me up. You go to a marathon and there's like 50 or 100 porta potties there, and there's 20 people in line at each one of them, and everybody is nervous about the start of the race, and they're in line. Everybody's got to pee, and then everybody goes over and the race starts, and they have about 3 porta potties on the whole course because nobody makes urine while you're running. Okay? So you might make urine for the first 2 miles before you really get cranking. But after that, your renal arteries are going to compress down, and you're really not sending hardly any blood to your kidneys. But your body figures, what the hell, we don't need to make urine. We don't have to purify our blood for a couple hours. But that doesn't work so good if it takes you 6 hours to finish the race, because then you're kind of wishing you had purified your blood a little bit and you weren't so damn sick. But anyway, so the renal system is another one that doesn't get enough. Sending everything you can, your skeletal muscles, lungs, heart. But one thing we always do, one thing our body always does is it preserves our blood supply to our brain. It doesn't matter whether we're laying around sleeping, whether we're exercising, whether we've bled, or whatever. Our body does everything in its power to keep the amount of blood to our brain correct. Why? Well, just think how helpless you are if you're unconscious. You're kind of gonzo. So our body does everything to keep that blood flowing to our brain just right. This is kind of a neat slide. Please don't waste much time with it, but here's a couple of examples for running. If you're running at rest, you're putting about 1,200 cc's a minute to your skeletal muscles. If you're doing really hard running, you may be going up by tenfold, sending 12,000 cc's a minute to your muscles. Your heart gets a little bit more because it's beating faster, but look at this. Your brain gets exactly the same amount no matter how hard you're exercising or whatnot. Your kidneys may be getting 1,100 normal at rest when you're in rest and digest. When you're really exercising, way down low here. Total cardiac output, total amount of cc's you're pumping at rest may be about 5,800 light exercise. And then it can quadruple almost up to under severe exercise. Yeah?
What about if you take drugs? Would that affect your blood supply in your brain? Any kind, even if it was like prescribed or if it was like cocaine or anything like that?
I would just say that taking drugs usually does not affect the blood supply to your brain as much as it affects the neurotransmitters that are released in there. Like when you take crack cocaine, it causes your body to release all this dopamine into your brain, and when it releases dopamine, that makes you feel really great. And you get really high. And then you spend the rest of your life trying to get that high again, but you never can because you'll never have that much dopamine stored up in your brain again. Anyway. this is another interesting slide. This is kind of my Lance Armstrong slide. You take a normal guy, his heart weighs about 300 grams. A real trained athlete might have his heart weigh as much as 500. And indeed, Lance Armstrong's chest x-ray, if you look at it, his heart is about 2 or 3 times bigger than normal. Okay? And that's because his stroke volume has gone from 60 up to 160. He can go much bigger stroke volume. He can also beat it faster than you and me. If I run my heart rate up to about 130, I can hold it at 130 for about 3 minutes, and then I'm just exhausted. He can run his up to, I can tell you, he can run his up to 210 and keep it there for 5 hours. And that's what long-term training and building up all these enzymes and so forth does for you. A little EPO gives you a little more blood too. So his cardiac output can be 6 times what ours is. His blood pressure goes up a little bit, but not tremendously, really. Yeah.
What happens when an athlete like that quits their professional career like a Lance Armstrong does, or has, and isn't working out 8 hours a day training like that? What happens to the heart then?
It pretty much goes back to normal. You use it or lose it. His heart will probably always be in better shape than ours, but it'll decrease in size, it'll decrease in capacity and so forth as time goes by and he doesn't train. Shock is a term. It means that you don't have enough. You don't have enough blood. A lot of people define shock not so much as blood pressure, but just as perfusion. If you do not have enough blood flowing through your body to provide the things to your body that you need, you're in shock. Now, this doesn't mean like, oh, I'm in shock, I just saw something awful. That doesn't mean that. This is the physiologic, the true meaning of shock here. So, most of the time, we can compensate for shock and for blood loss up until we've lost more than about 20% of our blood volume. Now, think about it. How many liters of blood did we have in us? 5 liters. That's about 10 pints, right? So we could lose 10 pints, 500 cc's to a pint. We could lose a huge pile of blood on the floor is 1,000 cc's, and that'd still be under or right at 20%. So it's not until we lose that much that things start even changing, that our blood pressure starts going down and so forth. If we can't bring our blood pressure back to normal, that's what we have to call shock. And so what does our body do to compensate for that? We've been in a car accident, we got these bad cuts, we bled a bunch, we've lost 3 units of blood. But bleeding is pretty well stopped. The EMTs have come, they've wrapped it up, they've got a tourniquet on this one arm that was bleeding a lot, and so forth. Now what happens? Well, mostly we can still recover from that without requiring blood transfusions. We can usually start pulling all of our extra fluid out of our interstitial space, all that fluid that's sitting there between all those cells in our body. We can start pulling that back into our bloodstream and making up for the stuff we just lost. Aldosterone is a hormone. Remember we studied it. And what does aldo do? Sodium reabsorption causes us to hold on to sodium, and if we hold on to sodium, we're going to hold on to fluid. So basically, it's going to make us quit making pee, right? ADH, what's it going to do? Antidiuretic hormone, where does it work?
Kidneys.
Works in the kidney so that we don't diurese. It's antidiuretic. So we don't let hardly any fluid go out with our urine. What little urine we're making under that situation is very, very concentrated, just to get rid of some wastes, Thirst increases, we want to drink. Erythropoietin turns on, and stimulates red cell production. Remember, erythropoietin is the thing that raises our hematocrit, raises our blood count, and that athletes use as a performance enhancer to raise their blood count even when maybe it shouldn't be. The other thing that causes erythropoietin to be released is elevation. Right, going to elevation where there's less oxygen, we automatically kick on our erythropoietin to make more blood. Okay, so here's a nice simple diagram. It tells you everything we do to compensate for losing a bunch of blood. Stupid slide, sorry. Okay, we have some special regions of our body that we handle a little bit differently. I already told you about one of them. I told you about the brain and how we work really hard to keep the amount of blood flowing to our brain normal so that we can stay alert and conscious and protect ourselves from the tiger in the room. Also our heart and also our lungs. Now let me think about that. Blood flow to the brain is top priority. It has a very high oxygen demand. It needs a lot of blood. It needs a lot of oxygen. But what happens is when all the other blood vessels in our body shrink down and go into vasoconstriction, the ones going to our brain open up and dilate in order to keep the flow normal to our brain, even though it may be really low to the rest of our body. A stroke. Wow. Yes, sir. Let's answer a question.
The vessels that dilate instead of constrict, are those superior to the circle of Willis, or are they going to be the carotid, jugular? What is it?
Carotids and the circle of Willis and the cerebrals, all arteries up in the head, and the little ones too.
Are you implying that those vessels are different than the rest, or are they?
Yes, they are. They respond differently to low blood pressure. Most blood vessels, when you have low blood pressure, go into contraction in order to raise your blood pressure. But you got to remember that all the rest of the arteries in your body, the reason they're going into contraction and vasoconstriction is to allow less blood to flow to your arm, for example, so that that extra blood is now available to go to your brain. And then your brain blood vessels do react just the opposite way. So that's why these are special organs, cardiovascular adaptations, which are special. A stroke is also called a CVA, a cerebrovascular accident. That's caused by several things. Mostly it's caused by a blockage of one of your arteries in your brain. If a piece of plaque, usually this is a piece of cholesterol, breaks off and goes up and clogs off an artery in your brain, then that area of your brain is going to die because it's not going to get enough oxygen. And depending on what area of the brain it is, that's the deficit you're going to have. So if it goes to the part on the right side of your brain here in your motor strip, you can't move your left arm and your left leg. If it's a smaller area, it might just be your left hand. Get it? If it's a big stroke, you may be both paralyzed and numb on the whole side. The other way is to have a rupture of a cerebral artery. I have some pictures of a carotid angiogram of a cerebral aneurysm I'll show you in lab probably. That could have broken, it didn't. But anyway, anytime you get a stroke, basically it just means you're not having blood flow to that particular area of the brain. A heart attack, this is in the heart, is the same thing. You saw that video the other day about John, right? And, his blood flow was blocked to a piece of his heart muscle. And it can lead to all these bad things. Angina or angina, depending on whether you're from the South or not, is chest pain that's reversible. In other words, you're not getting enough blood flow to that area of heart muscle that it starts to hurt you, but usually it clears up over a few minutes, and that piece of heart muscle doesn't actually die, but it gives you recurring pain. That's called angina. If the pain lasts for more than 10 minutes, though, everybody says there's been damage. There's been some heart cells die. The more die, you can go into heart failure and certainly go into death. Obviously, during that time, also, those cells become very irritated and start firing off with an ectopic rhythm like we showed the other day, and that can be a big problem too. Okay. The other special area is the lungs. Now, don't look at that slide for a minute and just think about this. If you just think about this one time, you'll get it. You'll always have it. Your lungs are there to breathe, right? And what you want is you want to have the proper mix of air and blood flowing to that region of your lung that is getting the air, right? Because it doesn't matter if it has air, if there's no blood flowing through it, that doesn't do you any good. By the same token, if you've got, what's the opposite? If you don't have blood, but you do have air, that doesn't do you any good either. So here's the deal. If you have a high oxygen level in, say, this lobe right up here, it has very good oxygen levels in it. This area down here doesn't have very good oxygen levels in it. Where do you think you would send the extra blood? Well, in the rest of your body, you would send the extra blood to the areas that have low oxygen content in order to increase their blood and increase their oxygen, right? But it's just the opposite in the lungs. Why? Because if there's high oxygen, you want to send more blood there so it can pick up more oxygen to carry to the rest of your body. And just the opposite. If there's not oxygen, like down here in the lower part of your lung, maybe the alveoli down here are full of fluid, and there's no oxygen. When you breathe in, you're not really breathing oxygen down there. Do you want to send more blood there? No, you want to send less blood there. And so the blood flow in the lungs is kind of backwards. You'll learn more about that next term. Yeah?
So if the alveoli down here are, have some sort of infection or something,
Yeah.
and they're not sending as much blood, can that cause damage long term?
Sure.
Okay.
So you want to, to treat that problem, you want to be working on that part of the lung. You want to be giving them antibiotics. You want to be coughing them and pounding on them and rolling them around and getting them to cough up all that snot that's down in there, blocking off the oxygen as well. The pulmonary circuit. Wow, that's a fancy picture. What do you think what I'm supposed to talk about here? Well, this is kind of jumping ahead to next. This is where the oxygen and the carbon dioxide are going to exchange. This is why we want to take deep breaths. We want to fill our alveoli up with oxygen, and then we want plenty of blood to be going right past it right here, and that allows these blue cells that are coming in that don't have enough oxygen, allows them to pick up oxygen, allows them to drop off carbon dioxide, and off they go back to the rest of the body to provide oxygen. In goes the good gas, oxygen. Out goes the bad gas, carbon dioxide. Keep that in mind. That'll carry you a long ways in the respiratory system. So, we have two systems of blood. Remember, we have the systemic circulation that pumps out through the aorta and goes to our whole body. And then we have the pulmonary circuit, which just pumps to the lungs, goes back from the lungs back to the heart again. Well, about 84% of our blood at all times is in the systemic circuit. There's not that much in our lungs, comparatively speaking. But just remember that every drop of blood that flows through the systemic circuit, when it comes back, then it flows through the pulmonary circuit. Same amount of volume, it's just that there's not much there at any one time. Okay, let's talk about the major arteries. And I probably don't even need to talk about this because I could just say, y'all look at this in the book, but I'll talk about it anyway because I found it kind of interesting. So let's go over the arterial system of the body. And let me just tell you that when you're learning the arterial system of the body, just know that the arteries change names a lot. In other words, they're flowing along, and it's the brachial artery, and it goes along farther, and it changes names. Okay? So listen to me as I go through this. So here's the aorta. We call it the ascending aorta, where it comes out of the heart and it's going up right there. And then it enters the aortic arch, which is this curvy around thing here. And then it goes down the back, and that's called the descending aorta. So there's three names for the same tube, right? Just at different places. The first branch off of the aorta is what? What? No. What are the first two branches off of the aorta? Coronary arteries. Remember, they live right in the coronary sinuses, which are just that far above the aortic valves. Thought I was trying to trick you, didn't you? Thought that was tricky. Okay, well, the coronary arteries are the first branch. All right. The next first branch on this picture here, maybe it was the laser pointer that confused you, is called the brachiocephalic trunk. Now, think about that word for a minute, and it won't be hard. Brachio means arm. Cephalic means head. Okay, so this is the right brachiocephalic trunk, and the reason it's called that is because it's going to supply this arm and that side of the brain. Okay, so it only goes up there a little ways, and it splits, and when it's the first split off of it is this one here, and it's called the right common carotid artery. The common carotid goes off there to go to the brain. Once it's done that, then we don't call it the brachiocephalic trunk anymore. We call it the right subclavian artery. Okay, subclavian, it's behind the clavicle. It's in the chest. Okay, subclavian artery is in the chest. As it comes on out here, so here it comes now, comes on down here, it goes out of the chest, it goes over the first rib really, comes behind the clavicle here, and it changes names, and we call it the axillary artery, the armpit artery. Okay, so once it goes out of the chest, it goes into the armpit, it's called the axillary artery. Goes a little bit farther, and now it's running along the arm bone there, and it's called the arm artery, and we call it the brachial artery, which you see over here. But basically from the armpit down to the elbow, it's called the brachial artery. Arm, brachial, not hard. At the brachial, at the elbow right here, it splits, and it splits into the radial and the ulnar arteries. Radial, radius, radial side of the thumb, right thumb side. Ulnar, down ulnar bone, right here, runs down there. So you've got a radial pulse right here. You can feel it. How many of you can feel your ulnar pulse on the other side? Most of you probably can't. Can you? It's deep down in there, but it's hard to feel because it's so deep. The radial one, you can see it sometimes because it's so close to the surface here. So the radial artery is the one we always use to check pulses with. Now, I love doing this little thing. I may do it over the lab again, but I'll try it here. So you may think, well, I wonder which artery supplies the most blood to my hand. Be nice to know. And the other reason that you'd like to know whether that both arteries are open is if you were working in an ICU and you were going to put a radial artery line in, you're going to take a little catheter, stick it right into the radial artery, feed a little plastic catheter up there, and hook it up to a monitor, and it's going to measure the patient's heartbeat, every heartbeat, okay, a radial artery line. But you don't really want to do that if their ulnar artery is not working good, right? Because if they didn't have an ulnar artery, and you clogged up or boogered up or somehow their radial artery, they could lose their hand. That wouldn't be a good deal. So we always do what's called an Allen's test. An Allen's test is a way to check that both arteries are working just fine. Okay? So here's how we do it. We have the patient say, okay, Mr. Jones, squeeze your hand really tight. Squeeze it really tight. And then I'm going to occlude both of your arteries. I'm going to include your radial with my index finger there, and your ulnar artery with the other one, and watch what happens. Okay, I got them both occluded. Stays white, doesn't it? Now what happens, and count the seconds here, ready? I'm going to release the radial. Ready? 1, 2, 3, 4, 5, 6, 7. It's kind of getting pink, right? 7 or 8. Okay. Now what happens if I release the ulnar? Include them both again. White. I'm going to release the ulnar. Magic! So which one's bigger? The ulnar is much bigger, even though we can't feel it. But keep that in mind. Ooh, magic. Yeah.
It feels weird when you do it too. When you really.
That's right, because you're starving your hand for blood. Yeah. It's like kids doing that choking thing. It's really stupid. All right, so anyway, we've got a radial and an artery. Arteries going down the arm, and then there's these palmar arches that connect the two, and that's why it really doesn't matter if you lose one of them, as long as you've got either your radial or your ulnar intact, the blood can circulate through the arches and supply the whole thing. Okay. All right, so that's the blood vessels. That's all the blood vessels in the arm. Let's go up the neck. If you go up the neck, you just should know that there is a common carotid artery. It goes up into your neck, and right about here in your neck, you can feel it, or you're feeling your big pulse right there. That's where that's called the carotid bifurcation, where the carotid splits, and it divides into one branch called the internal carotid, which is going right up here, and the internal carotid goes straight into your brain. It doesn't have any branches at all. It just goes straight into the brain. And you remember, and then the other one, the external carotid artery, which is this one here, it goes all up here through your face and your cheeks and all these muscles and your jaw and your eyeball, not your eyeball itself, but your orbit and so forth, everything up in here. External carotid. Now remember, we had two major arteries that carried blood to our brain, and they were the carotid and the vertebral. And you remember the vertebral actually comes off way down here. It comes off in the chest, and then it follows and goes up through all those intervertebral foramen. That's not right. Transverse foramen in the cervical vertebrae. Remember that little extra hole out there on the side of the cervical vertebrae? So the vertebral goes up through that as it goes up through the back of the neck here, and then it goes into the back of the brain, and it joins in with the circle of Willis as well. Okay. That's it. All right, let's follow the rest of the aorta. The aorta goes here, arch of the aorta, descending aorta, comes down here to the diaphragm, and then it gives off three branches that are unpaired. We have three unpaired major arteries in the abdomen, and you need to know these. The first one is this big one right up here, and it's called the celiac trunk. It's right below the diaphragm, way up high in the abdomen, and it branches and sends one branch to the liver. It's called the hepatic artery. It sends one branch to the spleen. It's called the splenic artery. It sends another great big branch to the stomach. It's called the gastric artery. Okay? They all come off of the celiac trunk right here, up high. Coming down a little bit below that, there is another one, and this is I'm having a hard time seeing that. The next one down there is the superior mesenteric artery. Superior mesenteric comes out right in the middle, and it goes down, and guess what it supplies? The mesenteric. So therefore, what it really supplies is the intestines. It doesn't supply the stomach because that came off the celiac, remember, but everything from the duodenum on down, almost down to the splenic flexure of the colon is supplied by the superior mesenteric artery. All of your small intestines, really. get their blood from the SMA. The last one, the last of the paired vessels, is this one down here low. It's called the inferior mesenteric artery. The inferior mesenteric supplies the left colon over here, the sigmoid colon, and part of the rectum going out the bottom. So that's the three unpaired arteries of the abdomen. The first being the celiac trunk, the second being the superior mesenteric, the third being the inferior mesenteric. Then the aorta gets down, well, actually there's a couple more, there's several arteries that are paired that come off there, like the renals. There's two renals, one on each side. There's an inferior diaphragmatic that goes to the underside of the diaphragm. There's a artery that goes to the adrenal gland that goes off of the aorta on each side. And there's several lumbars that supply levels down there. And then there's this other one that's kind of weird because it doesn't seem like it should be here. It's called the gonadal artery. The gonadal artery is a paired artery, one on each side, but notice that they come off right up by the kidney. Now you'd think, no, wait a minute, way up there? The gonads are way down there. But that's just the way they are, because if you'll remember, and when you study development, you'll know that the male gonads form up by the kidney, and then they actually migrate down. They go through the abdominal wall and finally out into the scrotum. Okay, but they get their blood supply from way up here high, gonadal artery. Same with a woman's ovaries. The ovaries are formed way up here high, and they migrate down into the pelvis, and they drag their arteries down with them too, the gonadal arteries. Now, gonadal is an asexual name. So what we really call them is we call them the testicular arteries in the male, and we call them the ovarian arteries in the female. Okay? All right, so here comes the aorta comes down to here. It comes to this point right here, and it divides. The first major bifurcation of the aorta leads to the two common iliac arteries. Common iliac arteries. They're pretty short. They're only about this long going in each direction down there. Common iliac go down to this point right here, and then there's another branch that comes off the back, which is called the internal iliac. And at the point that you give off the internal iliac, the one going straight on becomes the external iliac. The external iliac is the one that appears down here at the groin. When you get to the groin, it changes names again, and it becomes called the femoral artery, femur, from the crease right here, the iliac crease, the inguinal crease. This ligament right here. Once it gets below that, it's called the femoral. It gives off a deep femoral called the profunda femoris, or the deep femoral, which supplies all the muscles to the leg, all these muscles in the thigh, and then it keeps on going straight, and it becomes called the superficial femoral artery. And it just carries blood straight down to the knee, where it becomes the popliteal artery. Remember that? And then it goes on down the leg and splits a couple more times, but we'll call it good there.
So having a popliteal, we don't need to worry about the anterior and posterior tibial.
Yeah, you do. After the popliteal, it becomes the anterior and the posterior popliteal.
Tibial.
Posterior tibial. Now, let me just show you, when you're home tonight in bed, everybody ought to reach back here behind your medial malleolus, on your medial side. Right back there behind it, right there, is another easy place to get a pulse. That's the posterior tibial. Okay? Now, the anterior tibial actually runs up through here, and then it curves and goes across the top of your foot. And running right across your foot, underneath your shoelaces there, you have to feel around for it because it kind of varies an inch or two in different people. That's called the dorsalis pedis. The dorsalis pedis artery is another one that's easy to feel if you feel for it. So we used to do bypasses in people that had blockages. Here we are on the next slide. Usually the place that got occluded was here in the popliteal artery. and they wouldn't be getting enough blood to their foot to keep their foot alive. So we would go up here into their femoral, sometimes all the way up to the groin, and run a bypass from there down here below the knee, usually into the posterior tibial or into the anterior tibial to supply blood to their foot. So here's a anterior tibial. Anterior tibial comes on down and becomes the dorsalis pedis. I think I've said enough. I think I said all this before without a picture, amazingly enough. Okay, so just remember that the subclavian arteries, which are in the chest, becomes the axillary artery when it gets into the armpit. It becomes the brachial artery when it gets out into the arm. Arteries down here become the common iliacs. Then they bifurcate with the internal. They become the external iliacs. Then they change names again when they go into the inguinal ligament here, and they become the femorals. Then it changes name again when it becomes the popliteal. Okay, so I think I've said enough of this. I said that the internal carotid, which is the one that goes up to your brain, it basically divides into three big branches. These are all branches of the circle of Willis, actually. One is called the ophthalmic artery. Where do you think it goes?
Probably the eye.
Probably into the back of the eye. Remember that little artery that came in through the back of the eye, through the optic nerve? Remember that? And then when you looked in the disc, you saw the artery coming out the back of the eye. That was the ophthalmic artery that supplied the retina. Then there's the anterior cerebral artery, which supplies the front half of your brain up here. And then there's the middle cerebral artery, which kind of supplies the middle part. The blood supply to the occipital lobe is going to come from the vertebral artery in the back. Anyway, that's good enough. Here's a nice close-up picture. This is a nice picture of that vertebral artery. I said it comes off down here off the subclavian, and it comes up and goes up through those transverse foramens on its way up to the brain. Cool, huh? Notice here's the first rib, and where the subclavian artery goes across the first rib and goes out here into the axilla, armpit, it changes names. Now the reason I tell you that is because we're going to have some cats pinned, and we're going to have some models pinned, and pay attention to where the pin is, because depending on where the pin is, depends on what the name is. Get it? Okay. Here's the undersurface surface of the brain that I just mentioned. I said the big three that the carotid supplies are the anterior cerebrals up here in front, the middle cerebrals kind of doing the main part of the brain, actually the middle part, and then the third one is the ophthalmic, which I don't see drawn on that picture, but it comes off the circle right up here and goes into the back of the eyeball. Once again, the three unpaired arteries, the celiac trunk, the superior mesenteric, most all of the small bowel, and then the inferior mesenteric. Don't forget about the gonadals, because they're way up high here. They're above the internal mesenteric, even though they supply organs that both live south. I don't expect you to know all of this, but you just know that it's very important that all of your intestines have blood supply. If they don't have blood supply, they die. And that's usually a pretty calamitous event. So this superior mesenteric artery, the second of the paired arteries, comes down here. It supplies the entire small intestine and most of the right colon and most of the transverse colon as well. Notice there's arteries to the stomach, the pancreas. Here's the inferior mesenteric artery. All it supplies is the descending colon and sigmoid and part of the rectum. Here's the arteries down the leg, which I think we've said enough about. Okay, now, how about the veins? Well, geez, Doc, you got to make us learn all the vein names too? Well, all of the veins are named exactly like the arteries. except for these exceptions. Okay? They're really not very important. Basically, we don't have a carotid vein. We call them jugular veins. So we got carotid arteries and we've got jugular veins. Okay? We don't have an aorta down there. We have a vena cava. Vena cava, inferior vena cava, collects all the blood from the iliacs down there. They fuse together. Instead of coming together to form an aorta, they come together to form the inferior vena cava and then come on up to the heart. And we also have a superior vena cava that collects all these blood vessels up here, puts them together to carry them down into the, what chamber of the heart does that go into?
Right atrium.
Right atrium, very good. Another one that's different is called the saphenous vein. The saphenous vein is probably the most operated on vein in the body. The saphenous vein runs from the posterior, right here behind your medial malleolus, right alongside the posterior tibial, and it comes right up your leg, right up in through here, and goes all the way up to your groin. And you can do just fine without it. So that is the vein that usually that we take out in order to use for bypassing other things. If you want to use it to bypass the heart, to make those vein grafts in the heart, to do FemPops, femoral to popliteal bypass, you use the saphenous vein. Now you have to turn it around backwards. Why? It's got valves in it, that's right. So you have to turn it around backwards so the top becomes the bottom and the bottom becomes the top. Because the blood flows just fine in the other direction. And another set of vessels that are named differently are the hepatic veins and the hepatic arteries. I'm going to tell you don't worry about those right now. We will learn that in great detail when we get to the liver and study digestive tract. And then we have another weird one in the belly called the portal vein. This is just all the systemic veins that I think I've talked about already. Also remember that the blood flow in the brain, remember those dural sinuses? Remember how the superior sagittal sinus and the inferior sagittal sinus, and they went back to the straight sinus, and then they went to the transverse sinuses, and then they flowed down into the jugular vein. Get back. So that was kind of different as well. Here's the way they go. They go superior and inferior sagittal sinus, into the petrosal sinus, into the occipital sinus, into the right and left transverse sinuses, which actually go out laterally. Then they get into the straight sinus, which then goes into the jugular and comes on out. Here's that beautiful picture. Here's the superior sagittal sinus, remember that? Inferior sagittal sinus, they meet back here at the petrosal sinus. They go back through the straight sinus, back here to this meeting point back here on the back of your head. And then they go out through two transverse sinuses out on either side, and then they wind their way down here and form the jugular veins right in here and go down south from there. What is a portal system? We've done this before. What's a portal system? We had one in the pituitary gland. Remember a little portal system? Yeah.
So when it skips the heart, it just goes directly to the veins.
Yeah, it goes through one capillary system and then it goes to another capillary system without the heart being in between. Okay. Well, we have, and this is by far and away the most important portal system in the human body, the hepatic portal system. And the reason it's important and that you should know something about it is that basically what happens is when the blood, when we absorb food through our intestinal wall, then those veins that drain the intestines are full of food and fat and proteins and everything. And it would be kind of silly to just take that blood and let it go back to the heart to be circulated around again. What would really make more sense is if when we collected all that food, we put it into another portal system and then took it straight to the liver. And that's what this is. That's why this is called a hepatic portal system. The hepatic portal system, the blood is carried straight to the liver, and that nutrient-rich, fat-rich, protein-rich blood that just came through the wall of the intestines is taken straight to the liver. where it gets processed. This is what the portal system looks like, just so you know. So there really aren't veins that go from the colon here or the small intestine and they don't dump into the vena cava and go back to the heart like you'd think they would. Instead, what they do is they all go up here to this big vein called the portal vein, the hepatic portal vein, and all of this blood from all of the intestines goes through here goes straight into the liver, and then it percolates through the liver where it can take all that stuff out, and then it puts it back into the vena cava. I'll just leave it at that. All right. Now let me give you my little spiel about fetal circulation. This is one of the great miracles of life in my mind. You've heard this before? All right, well, think about it. Think about being a baby. We're going to talk about the changes that occur in your blood system, in your circulatory system, the instant you were born. Okay? Because I think the beauty of this is not that it's that big a deal. The beauty is that it was so well prepared for. Okay? Now think about this. When you're a little fetus inside your mommy's uterus, where do you get your oxygen from?
Your metal
Where?
through the uterine.
Through the umbilical cord.
Umbilical arteries.
Through, where does it come from, though? Where does the umbilical cord go to? The placenta, that's right. The placenta is this big old thing that's literally about that big, sitting on the wall of the uterus, where baby's blood flows through it, and it exchanges oxygen with mama's blood that's flowing through the uterine wall. Okay? All right, so that's where you get your oxygen. So then, do you need to breathe? No, right. So then, do you need a pulmonary artery to carry blood out to your lungs inside your mama? No, you don't. You really don't even need a right side to your heart, because all that does is pump blood to your lungs, right? And since when you're in mama, you don't need to pump blood to your lungs, so you don't. Okay, so let's think about that. Now, how does blood get from baby's heart to the placenta? Through the umbilical cord, come back from there. Never thought about it, did you? Well, it's got to get here, right? It's got to get to the baby's belly button, right? What it does is it goes down the aorta inside a baby, goes down the iliacs, and through the iliac, it takes a turn and comes out by the bladder in front, follows the inside of the abdominal wall, right up through here, to the belly button. And then it becomes the umbilical artery, and the umbilical artery then goes out through the umbilical cord, right? Goes out to the placenta, gets its oxygen, so now it's oxygenated. But wait a minute, it's coming back, okay? And since it's coming back, even though it's now oxygenated, we call it the umbilical vein. That's right, because remember, veins are always going back to the heart. So it comes back through the umbilical vein, goes back through the belly button. Where does it go from there? It's got to get up to the heart, right? Well, it comes in through your belly button and it turns north, runs right up through here, and then it actually goes through your liver in a little tube called the ductus venosus, ductus venosus, and then it enters straight into the vena cava, and then it goes straight back to the heart. Okay? So then, but I just said it doesn't really need to go to the lungs, right? But nonetheless, here it is coming up the inferior vena cava. What chamber of the heart does it go to? Right atrium. But you remember, the right atrium has that little hole in it. There's a hole called the foramen ovale that goes between the right side of the heart and the left side of the heart. And because the blood pressure is a lot higher on the right side of the heart now, it just goes straight through that, goes into the left side, and completely bypasses going to the lungs at all. Okay? But then some of it does. Some of it still goes out through the pulmonary artery. And when it gets out through the pulmonary artery, it doesn't really want to go into the lungs because it's really hard for blood to flow through the lungs when the lungs aren't full of air. And remember, when you're a little fetus, you're not breathing, and your lungs are completely collapsed. They're full of water, and it's really hard to pump blood in there. So there's another opening. It goes between the pulmonary artery and the aorta, which is called the ductus arteriosus. Okay? And normally blood would go the other way through that, right? Because the blood pressure is much higher in the aorta than it is in the pulmonary artery, right? But in pregnancy, in utero, it's just the opposite. The pressure is actually higher in the pulmonary artery than it is in the aorta. So it goes through that and takes that bypass. Instead of going out through the pulmonary artery, it takes the ductus arteriosus, goes into the aorta, and then goes on back and circulates around, goes back and gets more oxygen out through the iliacs. All right. Now, so the whole thing here is that the lungs aren't full of air, so it's very hard to push blood into the lungs in utero. And the other thing is, you don't need to send any blood to the intestines, that's for sure, right? So we just bypass that. All right, so how does it work? Well, let me show you some pictures. Remember that our respiratory function is not working at all in utero, and our nutrition is not used. We don't eat anything or get any of our food from swallowing it in utero either. We get all of our nutrition from mama through that umbilical cord. All right, so how does the blood get to the placenta? Well, it goes out through a pair of umbilical arteries, and they come off of the internal iliacs. Down here in the pelvis, the internal iliacs, so they come up alongside the bladder, come up to the belly button from the inside here, enter the umbilical cord. They go out, two umbilical arteries go out, one umbilical vein comes back. Anybody ever been around for a delivery? Did you see them draw cord blood? Usually once the baby's born, you put a clamp on the placenta, and you take a needle and put a needle into the umbilical vein, draw a big tube of blood just as for testing, if need be. It's huge. It's easy to see. Anyway, so the blood comes back through this single umbilical vein, drains into the ductus venosus, which basically bypasses through the liver, because we don't need to go through the liver because we don't have any food in it, right? And the ductus venosus goes into the inferior vena cava. Before birth, our fetal lungs are collapsed, and our oxygen is supplied by this placental circulation. So what happens at the moment of birth? This is what's so cool. Baby comes out, you clamp off the umbilical cord, right? You cut the umbilical cord, take the baby, slap the baby on the butt, and what happens? The baby goes, ah! And then he goes, ah! And in about 2 breaths, the baby has completely inflated their lungs. So suddenly, what was a high zone of pressure, trying to get forced blood into the lungs, is now a very low level of pressure, and now the blood is more than happy to flow into the lungs. So therefore, the fossa ovalis, the foramen ovale, between the 2 atriums, snaps shut, because now it has higher pressure on the left than it did on the right. So the little flapper valve closes, and it scars up and becomes the fossa ovalis, right? And then the ductus arteriosus, which is that connection between the pulmonary artery and the aorta, it used to be easier for the blood to flow, instead of flowing out into the lungs from the pulmonary artery, it used to flow right up into the aorta, but now that's hard because it's so much easier to go on out to the lungs, so it just starts flowing out to the lungs. And then over the next day or two, the ductus arteriosus scars off, and it's gone. Okay? So, there's 3 bypasses in the child, or several of them, I think, here. The foramen ovale is one. It's the inner atrial opening. It's covered by a kind of a valve-like flap. It sends blood from the right to the left atrium, but at birth, that thing snaps shut. No more blood goes through there. The ductus arteriosus is a little short vessel that connects the pulmonary and the aortic trunks. And normally in utero, the blood flows from the pulmonary into the aorta because it's easier to go that way, but now it doesn't flow at all through it. It just goes on out into the lungs. Here's the ductus venosus. Remember, here's the blood coming back from the baby in the umbilical vein, which is the red thing here, the big red thing. Notice it just shunts right through the liver here, goes straight into the inferior vena cava. Now, what do you think happens to that when the baby's born? Well, once you've clamped this cord off, there's no more blood flowing through that thing at all, and it just scars off. Okay, you can see it later in life. You can see it at surgery. This part of it right here, at least. And so that just scars off and goes away. The blood now goes this way and goes out this way and goes into the lungs instead of cutting through that ductus arteriosus here and going up into the aorta. And the foramen ovale snaps closed, and life is good. So this is kind of the way blood flows through the neonatal heart. It flows through this pulmonary foramen ovale, and it flows through this ductus arteriosus, but they both close right at birth. I think I've said all of that. There's a bunch of heart problems that you can have, holes in your heart. This is probably the most common. This is the patent foramen ovale, or a ASD, an atrial septal defect, where there's just a hole between the 2 atriums. Sometimes you have to go in and surgically fix that. That's a hole in your heart for babies. Ventricular septal defect, same thing, hole between the two ventricles. The thing about these things is they don't really make the babies turn blue. They just make the baby pump the blood twice, because instead of it going around, it comes back. You see, it comes from the left side of the heart back to the right side of the heart. Then you got to pump it around again. I think there's nothing here that's very important. When you get older, your heart gets weaker, and your blood vessels get less elastic. They get more like calcified pipes. That is all. Yes, ma'am.
So I know that you can have only one vessel in the umbilical cord. What happens when that's split?
I don't believe that's true. I've never heard of that.
My friend just had a baby, and or maybe it was one less vessel in the umbilical cord, but there was.
They could have had one umbilical artery instead of 2.
Okay.
That would probably be okay. I never heard of that, though.
Yeah,
You got to have one going out, and you got to have one coming back. That makes sense? Anything else?